My name is Dr Gilbert. I'm from Ireland originally, and my background or my path to One Health, I would say, started with One Medicine. So I first studied human medicine in Belfast, and then after working for a couple of years, retrained as a veterinarian in Edinburgh University. And so I have both professional degrees and have actually worked clinically in both areas, sometimes even at the same time. But my interest sort of expanded from clinical work to working overseas in resource poor countries. And so after an initial job in South Africa, which was doing work in the townships, doing sort of veterinary care there, I worked for the Liverpool School of Tropical Medicine, researching onchocerciasis, looking at a new therapeutic regime for people, but using cattle as a model for that. I left Africa in 2000 and went to study in the London School of Hygiene and Tropical Medicine in veterinary epidemiology. That was interesting because it was actually taught between LSHTM and the Royal Veterinary College, so it probably was one of the first One Health courses, but it wasn't even called One Health then. It was purely a matter of spreading the teaching time between the schools. Once I finished that, then I worked in Afghanistan, and again another One Medicine environment where we were collaborating with the Red Cross on trying to do simultaneous vaccination campaigns for children and livestock, because often the incentive in that very challenging country is the livestock sometimes seem to be worth more than the children, which is very different from a Western perspective. So leaving there, then I went to China to work in SARS, because there was an animal reservoir initially believed to be civets, and then that went on to H5N1, avian influenza broke out just around that time. So I would say there was probably limited collaboration in that period, so One Health definitely had not kind of come to pass. So good examples of One Health where I've been involved, starting from sort of a baseline in China where there was a challenge of the sectors working together during H5N1. When I moved to FAO in Vietnam, there was already established sort of a joint multi-sectoral committee for control of avian influenza with Ministry of Agriculture, Ministry of Health, and that was complemented by the UN organisations also working together. There was one of the initiatives was a joint programme which was multi-donor funded, and so One Health was sort of starting there, and again, though it wasn't really sort of referred to as a One Health example, but very much joint, multi-sectoral, although that was very much at the central level. It was quite difficult to roll that down to lower levels. So at lower levels, there was generally people working within their own sector. Following that job in Vietnam, I moved to the International Livestock Research, and I remained in Southeast Asia. There was covering 6 countries. The One Health at that point was actually called EcoHealth, a Canadian version perhaps, but EcoHealth is very similar, complementary. I saw it as much more social science involvement than at least initially in One Health. We worked in each country. It was initially getting multi-sectoral partners together in a manner, and then asking them to have a joint priority that they wanted to do research in. So each country came up with a different plan for that. For example, in Indonesia it was rabies on Bali. Following that, another fairly recent example that I've done is, again, not probably called One Health, but is looking at schistosomiasis in Cambodia and Laos. It's quite a limited spread of Schistosoma mekongi. Only some 100,000 people at risk rather than the better known cousin Schistosoma japonicum. For both of these Asian schistosomiasis, there are zoonotic implications. In Japonicum it's cattle and buffalo, and China does a vast control in cattle to try and reduce the issue in people. In Cambodia and Laos, we're still not convinced which is the reservoir. It has been found in dogs and even occasionally in other species. But what we have to look at is dogs have an important reservoir. If you were to control it completely in humans and then stop the mass drug administration, would it then cause the schistosomiasis to come back? So it's a very complex environment, and certainly from a purposes of people's hygiene, behaviour, even nutrition and so forth. So that was a very interesting example. In some cases, to get a new approach across or accepted, people need to understand what it is. And so they would say, well, define One Health, what it is, what it isn't. And initially, I think we have to sort of give the examples and try not to let people be too focused on having to have a very strict definition. There's still a lot of debates amongst researchers. A few years ago at a meeting in Kunming, where the One Health advocates were coming together with the eco-health advocates in a meeting, and we were thinking, would they be able to collaborate and so forth, or would they feel that what you're doing isn't what I'm doing? And that was a very good indicator of people, because their minds are open, they were willing to work along a broader definition. There are a lot of people, even within UN organizations, within the research, the scientific community and governments, who are not yet convinced. They do want to see it, examples. I think we have to really continue to sort of try and build examples, expand to different things, and ultimately we do need to have some sort of proof of concept in a broad sense of where it would work against, and it being more effective to do a One Health approach rather than not. There's still some hierarchy and elitism, I would say. Sometimes human health feel that they should be always in the lead, whereas from my experience it's veterinarians and animal health who have often more open minds to begin with. And I think that from having done both sets of training, there's a reason for that. When you're training as a vet, it's much more community based with different ranges of pets, livestock, sometimes even wildlife, whereas hospital is really the main forum where you're taught as a medical student, at least that was my experience. And the other thing is a problem that we encountered during my time with ILRI is the acceptance of different methodology. For quantitative epidemiologists, normally with a biomedical background, sample size is very important before you can prove or disprove, whereas from a social science point of view, having 3 focus group discussions in a few villages makes their methods okay, but the quantitative people then go, but this isn't enough, how can we prove anything from this small number? So it's an acceptance and a respect of different methods. The leadership issue is a real problem as well, because it can be within the sectors. Is it health? Is it agriculture? But then especially in the lower levels than the national level, sometimes it's local authorities, governors, in the case of Vietnam, people's committees and so forth, who need to be in charge of this and be supported very much from the technical side. And funding probably is the last concern, because while we had this joint program in Vietnam, it was very much money from FAO went to animal health, money from WHO went to human health. It's challenging to make money flow between UN agencies, and even often worse, there's no actual mechanism. For example, the Ministry of Health to send some funds over to the Ministry of Agriculture to buy rabies vaccine for dogs or whatever. And so those are challenges that are difficult to address because it's right in legislation or policy of the country. Many people, again, especially in the government side, are thinking, oh, what will the international community bring to us next in terms of ideas or new things for us to understand, and sometimes to get the funding that's required to do things. And I do feel that this is a slow process of government, scientific community, and many of the players to come on side, to start working with each other. So we're looking probably in terms of decades rather than in terms of years for this really to become very much embedded in the way things are done. So I would say that the success probably is whenever we start doing One Health and not talking about doing it. And an interesting example is, can One Health be, is it required everywhere? So I worked during the Ebola epidemic in Liberia and Sierra Leone for a year. And although I went realizing it was a zoonosis that was originally from bats, possibly through non-human primates, the whole drive of the epidemic was really in the human-to-human. That was, of course, the usual clinical management, the epidemiology, surveillance, contact tracing, communications being vital, but a huge dimension that you could still refer to as One Health is people's behaviour and their concerns, sometimes conspiracies as well. So the social mobilisation, the anthropologists and behaviour specialists were also involved in the Ebola response at that point in time. And then following the successful control amongst humans in all three countries that were worst affected, then now we don't give up and say there it is controlled. Now the veterinarians and wildlife experts who had been probably fairly silent and not priority involvement, were now, it was their turn to come in, and in terms of considering the risk of Ebola coming back in those countries or others where the virus is known to exist in bats. So current work, I would assume, will be more focused on the animal and wildlife side. So we've learned a lot through Ebola. So that is a kind of a One Health example, which is longitudinal in terms of everything didn't happen at once. It didn't need to happen at once. It was involvement based on priority. We're trying to get One Health or EcoHealth embedded in the way we approach things. We want to see that there's a need. Not everything has to be done with the full range of expertise, but what will ultimately happen, should happen, is that we don't start saying, is this One Health or that One Health? We're just doing it. We're basically, governments are more dynamic in terms of being able to cooperate and collaborate across sectors, and as are donors and other UN agencies and other international national agencies, so that there is a means of getting things done. But I think we do have to go over the step of realizing that we can do better and collaborate more. Another one is, we have examples, we have experience, and many more than what I have given in this interview. And for all of you who are already convinced that it works, you're already thinking in a different way. So look at novel collaborations and approaches that could work here, and that also looking towards your individual contexts of how you can get buy-in and support, and ultimately that will help for things to be accepted rather than always being pushed as an international agenda, which is often associated with funds. So those are my two key messages at this point in time. Thank you.